computer use also. Anyway, I invite Dr. Marian Pauly for management of trichiasis. I think there's no need of introduction. Marian Pauly. She's a oculoplastic surgeon of Girdhar Institute at Karnal, Cochin.
Thank you, sir. So today I'm speaking about trichiasis. As the name says, it's actually management of trichiasis is little tricky. Okay. So we know trichiasis is misdirection of lashes, and in this context, I would highlight the management of dystrichiasis also. In dystrichiasis, you get an extra row of cilia within the tarsus behind the normal row of lashes. So trichiasis can be either primary or secondary. Primary, the follicle is distorted, but normally position lid margin. Whereas in secondary, follicles are normally aligned, but lid margin is rotated inwards, primarily associated with the entropion. It's a sequelae of SJS, OCP, etc. So dystrichiasis can be either acquired or congenital. So before going to the management proper, we should understand the anatomy of the lid margin. So we know conjunctiva, mucocutaneous junction, meibomian orifices, gray line, and anterior lamella. This anatomy is very important in management. So history is very, very important because first thing we should differentiate it from epiblepharon, especially in childhood. Epiblepharon is a fold of skin causing pseudotrichiasis. In that case, the management is different. Then rule out history of infections, autoimmune disorders like OCP, which is very common and it is missed nowadays, especially in case of chronic conjunctivitis. Then Stevens-Johnson syndrome, chemical burns, trauma, surgery. All this history has to be asked for when you see a patient with the trichiasis. So now look at the lid margin. You can see rounding of posterior lid margin and anterior migration of mucocutaneous junction, especially in cicatrizing diseases. Then anterior migration of mucocutaneous junction can be either focal or diffuse, and it can be associated with the posterior lamellar scarring, and there can be an associated symblepharon also. So all these things are very, very important when you manage the patient. Then look for signs of involutional entropion. Then rule out dystrichiasis, as I have already discussed. Epiblepharon also, look for extra fold of skin. So what are the indications for treatment? Suppose if the patient is asymptomatic, you can leave alone. That is no corneal, no photophobia, no irritation, no watering, no surface inflammation. So and disturbed corneal surface is also an indication for the treatment. So what are our goals? Make a continuous row of lashes, reposition the misdirected lashes, eliminate the lash that cannot be reposited, and reconstruct the lid margin finally. So I will just the treatment is divided into three headings. One is lash follicle destruction surgery, lash follicle reposition procedures, and then combined surgery. So coming to the destruction procedures. So this is a simple epilation where everybody can do in OPD, but this, we know this is temporary. And when you epilate, hold the lash at the root of the lash. If you hold at the margin, the lash can break and it will create more troubles than not doing the epilation, done under slit lamp. So second is radio ablation of lashes. Here we need local anesthesia, and we need a radio frequency cautery to do this. Fine needle is used along the side. The needle is inserted along the side of the lash for 2.5 millimeters. A radio frequency pulse is given for 5 to 10 seconds. When you give the pulse, you can see some white bubbles, and then finally just remove the lash. If you have done properly, you can see the lash bulb attached to the cilium. Here, I just want to highlight this, the role of mitomycin C in the management. Mitomycin C alone might not work, but along with radiofrequency ablation of the lashes, if you, after plucking out the lashes, you can inject mitomycin C 0.2% into that lash root, it prevents recurrence. So the study shows that the combined modality treatment gives around 90 to 95% result, that is no recurrence. Electroepilation, argon laser, I personally don't use. So coming to cryotherapy, cryotherapy is done when there is a row of lashes. So what happens is it destroys the follicles by freezing. We have in two ways you can do. Either you can split the lid, anterior lamella and posterior lamella, and then give cryo. The side effect is you can get hypopigmentation. And after giving cryo, just wait for 2 weeks. Most of the time, if you have done a good cryo, the lashes will fall off by itself. So coming to segmental trichiasis. So you can get 5 lashes in a segment. So in that case, radio frequency ablation results 80 to 90%. All other procedures not 100%. So if you excise that pentagonal wedge, you can get 100% success. So this is a case of trauma treated with pentagonal wedge and there is no recurrence. Coming to another surgical technique where you are excising the lash bearing follicles. So this is primarily you are excising the anterior lamella. So it is again using radio frequency cautery. So just give us with the radio frequency cautery, just excise 2 millimeter of the anterior lamella that bears the lashes. So finally at the end of the procedure it will look like this and leave it for spontaneous healing, and this is the post-operative picture. So lash repositioning procedures, I will skip some of those. So tarsal rotation, primarily what you are doing is rotating the tarsus. Second is tarsal advancement procedure. These are all done in cicatricial entropion with the shortening of posterior lamella. So in this case, this patient has come to us after multiple surgeries. So we have done posterior lamellar advancement with the tarsal rotation. So you can see in this, the tarsus, posterior lamella is very much shortened. Tarsus is incised above the scar, and the lid is split into anterior and posterior lamella, and the dissection is extended almost up to the eyebrow to advance, and then mucous membrane graft is placed. We have to keep a very big mucous membrane graft because all these are sometimes progressive condition which can cause recurrence. So this is the post-operative picture. Then another aspect is lid margin keratinization with the disc trichiasis and trichiasis seen in Stevens-Johnson syndrome. So you can see the disc trichiasis seen in this along with lid margin keratinization. So this can be managed with lid margin mucous membrane graft, and they will all do well. So to conclude, the pattern and cause of the trichiasis, patient and surgeon comfort should guide the treatment decisions. Evidence-based management decisions, actually management of trichiasis is always challenging because we can get recurrence. So always we combine 2 or more methods, and patient education is also very, very important. So thank you.
Thank you, Dr. Marian, for that very concise take on trichiasis, which is a very common problem that we all see in our